Welcome to the Leukemia and Lymphoma Society of Canada's webcast called Science Behind a CBC, Understanding Your Blood Work. In this presentation, Dr. Dallas will be reviewing the information behind your blood work, why you need to have them done, and what they mean in the context of your diagnosis. My name is Sonia Muto, Community Program Coordinator for the Leukemia and Lymphoma Society of Canada. I will be the host of this online event. During the webcast, you will hear only my voice and the speaker's voice. Since there are many of you, questions may be asked at the end, but only online using the chat function. The presentation will last approximately 45 minutes and will be followed by a 15 to 20-minute question period. The presentation is being recorded. Therefore, you will be able to listen to it again on our website while following along with the PowerPoint presentation. We will send you an email when everything is available online. Our mission is to cure blood cancers and improve the quality of life for patients and their families. We offer support to people affected by blood cancer every step of the way. Please reach out to us if need be. We have several informative tools such as fact sheets and booklets available on our website, llscanada.org. We also have a series of educational videos accessible on our website. I would now like to introduce our speaker, Dr. Karen L. Dallas, who has generously accepted to share her knowledge with us. Dr. Dallas is the medical lead for the Department of Hematopathology and Transfusion Medicine at Providence Healthcare in the St. Paul's Hospital. Over to you, Dr. Dallas.
Thank you very much. I wanted to really say thank you to the Leukemia and Lymphoma Society of Canada for inviting me to present here today. I'm American, actually, and I've worked across the States, Canada, and many countries in the developing world. So from that diverse perspective, I really want to say that I think these webinars are such a great resource for the patients, families, and providers here in Canada. So now, before I begin with my objectives, I just want to set the stage a little bit. So I imagine that most of us have at least some level of access to lab results, if not our whole charts, lots of which are actually lab results. And as patients with blood disorders like leukemia or lymphoma, you know that we doctors seem to always order more follow-up tests. Finally, as initially pointed out in a really infamous article from Mayo Clinic, over 70% of critical care decisions in the hospital are said to rely on lab tests, although you might not know much about the lab in the background. So, well, with today's session, as you can see on the objectives, you will learn to understand more about your blood tests so that you can better navigate your care, or if you're a family member, your loved one's care, or perhaps your patient's care. We're going to talk about the how, what, and why of lab tests, as you see listed there, so that you can go from feeling confused to feeling more confident the next time you see a page or maybe a screen full of test results. As you can see in the outline, we will spend the rest of today talking about several key blood, bone marrow, and body fluid tests. We could certainly spend the rest of today, and probably tomorrow as well, discussing all possible tests that are ordered in the medical laboratory, but rather I want to focus our attention on the more common ones that you'll see as a patient, family member, or caregiver of someone who has a blood disease like leukemia or lymphoma. But before I start the talk, I want to tell you a little personal story about myself. Before I ever became a hematopathologist, when I was just a student, I was admitted to the hospital with something we thought was lymphoma. And I had a whole bunch of tests done. There were a bunch of numbers, a bunch of acronyms, and I felt very overwhelmed by the whole process. So if any of you have ever been confused about why you need a certain test, or maybe why we're ordering it again and again, if you've ever felt like I did, that you wished you knew what some of those abbreviations meant, maybe you're ready to take a step with me inside a deeper look at what happens with all of those medical tests inside the laboratory. As you can see in this picture, the medical laboratory these days is filled with gigantic computerized analyzers, which is much different from the labs of the past. And we'll talk a little bit more about this when we talk about certain particular tests, but I just wanted to show you how high tech the lab is inside of your local hospital. Let's talk first about the two more, let's say, less common tests that were on that list before. Still, many of you have probably had a bone marrow examination. So bone marrow examination includes two parts, the liquid aspirate and the solid core of bone marrow, where we take out a little chunk of your bone to analyze. Why do we do two samples? We do different things with each sample in the laboratory, as I'll get to in a minute. And as you can see in the picture there, and some of you may have experienced, the bone marrow biopsy requires you to come into the hospital and have a needle inserted into the back of your pelvis, where we take both of these liquid and solid samples. So why do you need your bone marrow examined? Why do we need to look at it in the first place? Well, the bone marrow is actually the factory of all the blood cells. So in order to know exactly what's going on with the blood cells, we have to look at the bone marrow. If you've already been diagnosed, probably involved one bone marrow biopsy, and now we might want to see if you've responded to treatment. We would need to examine the bone marrow again. So I do these procedures very often on patients, and I often tell patients, well, it's like when you leave the car mechanic. You tell them you never want to see them again, but you always end up coming back. So bone marrow is something that we examine usually much more than just one time. And so how do we look at the bone marrow? We actually look at that liquid part right away. The same day that we take it, we'll be able to look at the liquid part under the microscope, and we can tell whether cells are normal or abnormal in that way. Sometimes normal looking cells are not actually normal though. That's when we have to do more special tests like flow cytometry, which you might also heard called cell marker analysis or immunophenotyping. So we'll get more into this test in a little bit, but suffice it to say that flow cytometry is very high tech, and we analyze cells one by one with up to 5 different lasers at the same time. Other fancy tests that we can do with the bone marrow is to look at the chromosomes and the DNA inside of your cells. That way we can see if you have certain genetic mutations that might lead to one leukemia or lymphoma. So what do you need to know about bone marrow, aspirate, and biopsy tests? Well, the final report usually takes about a week. Some of those special tests, like the chromosome and DNA analysis, might take a little bit longer, but the first report will be out in about a week. And there is always an interpretive report that comes out with this special test. So you should usually have something to read and that would explain to you what's going on in the bone marrow. To move on to the other test, this is a body fluid called the cerebrospinal fluid, and this is the fluid around your brain and spinal cord. Many of you might have already had this test as well. It's something called a lumbar puncture, and you would do this test either in the lying position or the seated position. We insert a tiny needle in between 2 of your vertebrae and gather a tiny bit of the fluid from around your spinal cord. So why would we need to do this test? So the CSF, the cerebral spinal fluid is actually a very special place in the body. They often call it an immune protected location. So the immune system doesn't have a very good way to surveil the cells that are in the CSF. So if leukemia or lymphoma cells are there, they might not get killed off by the immune system or by chemotherapy in the same way that they would in the rest of the body. So therefore, if your CSF is involved by leukemia or lymphoma, treatment options for you are often quite different than if your CSF is not involved. Sometimes we even inject chemotherapy right into the CSF. Equivalently, if your disease relapse, we also have to check the status of the CSF to see if you need a different treatment at that point. So you may need to have this test done multiple times as well. So how do we look at the CSF? We also look at it under the microscope. Although first we run it through one of those fancy analyzers that I showed you in the beginning slide. In those analyzers, we can get a cell count, so just a raw number of white cells and red cells in the CSF. There generally shouldn't be any, but if your disease involves the CSF, we'll get a high number of cells there. Then we make a slide out of it and look at it under the microscope. If there are a bunch of cells there, we use that same fancy technique with the lasers to look at them by flow cytometry. So what do you need to know about having a CSF test? Well, the turnaround time for a report there is about 1 to 3 days, depending on whether the CSF has cells in it and whether we need to do those special tests. And there's almost always an interpretive report with this test as well. The only case in which there would not be is probably when there are no cells there to report on. So now we'll talk about the more common tests that involve the blood. The first one is the complete blood count, or the CBC. If you live in Europe, you might call it the FBC, the full blood count. And so this one is run on one of those fancy analyzers, and it quantifies all blood cells that are in your circulation. The first component it looks at is the red blood cells, also known as the RBCs, and you'll see that listed as hemoglobin level. If you've ever been to donate blood at Canadian Blood Services, this is what they check at the beginning to see if you're eligible to donate. Many people would say this is your iron level, but they're actually checking your hemoglobin level, which is a surrogate marker for your red blood cells. They also look at the white blood cells, and the white blood cells comprise neutrophils, lymphocytes, monocytes, basophils, eosinophils, and then in the case of someone with leukemia or lymphoma, you might see a category that's listed as blasts or others. The blasts are the immature leukemia cells, and the others are usually a category where we put the lymphoma cells. So all of these white blood cells have very different functions. The one you most commonly would hear about is your neutrophils. Your neutrophils are the ones that drop precipitously when you have chemotherapy. They're responsible for engulfing and destroying any foreign bacteria or viruses in the body. Lymphocytes are important because they make antibodies to fight off infections as well. And finally, the last cell, or let's say fragment of a cell, is the platelets. The platelets are those tiny little guys involved in making a blood clot. In fact, they're not a cell at all. They're a fragment of a very large cell called the megakaryocyte, which is found in the bone marrow. But in the complete blood count, they're counted as one of the cells. Platelets also decrease a lot during chemotherapy, and this is important because it might cause bleeding. So with the CBC, in addition to the red blood cells, white blood cells, and platelets numbers, you will also see a whole bunch of abbreviations. So I just wanted to go through a few of the more common ones and tell you what they mean. So hemoglobin and hematocrit are listed on there. They're abbreviated, usually HGB and HCT. And that talks about the red blood cells, as we mentioned before. The hematocrit is usually written as a percentage, where the hemoglobin is written in grams per deciliter. Both of these values talk about the oxygen carrying capacity of your red blood cells. So reasons why these numbers might be important is if you're losing blood from bleeding, and that might be visible bleeding or occult bleeding. Sometimes we don't notice that we're losing blood through our stool or through our urine, for instance. Sometimes you can have hemolysis, where your red blood cells are breaking down within your circulation, and that also could be important. So when you have repeated CBCs, oftentimes it's to look at this hemoglobin value to see if you have enough oxygen carrying capacity. And if you don't, you might need a transfusion. We'll talk more about that in a minute. The next one on there, I noticed that I have made a typo. It's mean corpuscular volume. It's supposed to be MCV, and that talks about the size of the red blood cells. And the reason why this might be important is if you have nutritional deficiencies, for instance, you could have a low MCV. If you have a B12 deficiency, you could have a high MCV. Other things that can affect the MCV have to do with hemoglobin concentration inside the cell or membrane problems. And all of that will be important to your physician, but the main things are nutritional deficiencies with the MCV. The next one on the list is RDW, and that stands for red cell distribution width. As you might imagine, that talks about the range of different sizes of the red cells. This is listed in a percentage, so if you have a very large RDW, that means you have small red blood cells and large red blood cells, so giving you a wide distribution width of their sizes. And this might be important if you have mixed nutritional deficiencies. As I mentioned before, you can have small red cells with iron deficiency, but big red cells with B12 deficiency. Also with liver disease or transfusion, you can have large RDWs, and it all means something to your physician. The next ones on the list, MCH or MCHC, you might see them listed together. It all talks about how much hemoglobin is inside the red cells. So this is important because even if your red cell is big or small, we actually care about how much hemoglobin is inside of it, because that's what actually carries the oxygen. And another interesting one that doesn't have to do with the red cells, but you might see listed, and it's kind of confusing, is IG. It stands for immature granulocytes. And while these are not actually leukemia or lymphoma cells, they are immature versions of the white blood cells that are normally in circulation, and it might mean that you're getting an infection or that there's some other stress in your body which causes the bone marrow to produce immature cells instead of waiting until they're fully mature. So your care team would care about this number as well. There's many other acronyms and numbers that you can find on CBC lab results, but these are some of the main important ones, and I hope can give you some insight into what's going on with your blood. The next thing that we can do from a CBC blood sample is to make a peripheral blood film. This is also known as a blood smear. I had an old teacher when I was in medical school who said, "Oh no, it doesn't sound so good, blood smear. It sounds too barbaric. So let's be more technical and call it a peripheral blood film." Because there's actually a lot of technique involved in preparing a proper peripheral blood film. Back in the day, we actually used to do them very manually. And as you can see in the pictures on the right side, there's a dark drop of blood in the middle of that slide. And then we would use another slide angled at 45-degree angle to carefully spread the blood out so that it ends up into a one-cell layer and we can look at it under the microscope. These days, as I showed you with the fancy laboratories that we have, there's actually machines that make peripheral blood films perfectly every single time. So what the peripheral blood film allows us to do is have a very detailed look at all the blood cells underneath the microscope. There we can tell whether the cells are abnormal, whether they're immature, whether you have lymphoma cells there. We can look at the red cells to see if they are fragmented or whether there's evidence of hemolysis. We can even see parasites inside the blood. So the lab will reflex a peripheral blood film if your CBC values are abnormal or if there's anything abnormal that our fancy analyzers detect. So your physician never has to worry about ordering a peripheral blood film test. The lab always makes them if it's necessary. So the next thing we'll talk about is coagulation tests. So many of you have probably had coagulation tests done over and over again as well. The basic tests that we would see with coagulation studies are called the INR or the PT and the PTT. They're often seen as screening tests, and many of your physicians and nurses might think that they are a good test to order to evaluate your bleeding risk, or maybe even your risk for developing a blood clot. But in my expert opinion as a laboratory physician, the INR is really intended to measure warfarin specifically, which is a blood thinner. Many of you may have heard about this before. Patients who have atrial fibrillation, for instance, or patients who have developed a blood clot might be placed on warfarin to keep their blood thinner and prevent future blood clots. That's what the INR is really developed for. The PTT, on the other hand, is really developed to measure heparin. In fact, it was originally developed to screen for the bleeding disorder, the genetic bleeding disorder called hemophilia, which you may have heard of before. So these two specific coagulation tests have specific diagnostic purposes and have in recent years been probably inappropriately expanded to be seen as screening tests. So while you might have INR and PTT done often, it might not always accurately predict your bleeding or clotting risks. Particularly if you're on warfarin or heparin, these tests are very necessary, however. Other fancier tests can be done if these initial coag tests are proved to be abnormal. We can reflexively add on other tests like a one-to-one mix, where we mix your blood with a normal patient's blood to see if the coagulation number is correct. If they do correct, we know that you have a coagulation factor deficiency, and then we can go on to do specific coagulation factor levels. If that one-to-one mix does not correct, we know that your blood has an inhibitor, and we can go on to do specific tests to evaluate for a coagulation factor inhibitor. All of this is done in the background in the hematology lab based on the initial results of these two basic tests. To move on to the next topic, another test that can be done with your blood is transfusion medicine testing. And many of you have probably had these tests done on more than one occasion as well. So the first test we'll talk about is the type and screen. You might also hear it called a group and screen. The purpose of this test is to figure out your blood type or your blood group, which is the ABO, and the Rh factor, which is positive or negative. Myself, I'm group O positive. That's the most common blood group in humans at these days. This test is different from a cross match, but for physicians and nurses who are not laboratory experts, they might accidentally call it a cross match and mean the same thing. So the other thing that's included besides figuring out your blood type or your blood group is an antibody screen. And this antibody screen is looking for alloantibodies. Alloantibodies are antibodies that your body has developed against someone else's blood. So how could this happen? This might happen if you've had a previous blood transfusion, or if you've previously been pregnant before or had some other kind of organ transplant. All of these things would expose you to someone else's blood, and you could develop an antibody to a minor antigen on the surface of the red cells. The ABO antigens are called major antigens, and that's why we test for them. But the minor antigens are very numerous, and we can't test for every single one of them up front. So if you've had a transfusion, you might develop an antibody against one of those minor antigens. It's not common, and we estimate about 3% of the hospitalized population who's been transfused would develop these alloantibodies. But this is the very reason why we need to repeat that type and screen. In fact, we need to repeat it every single time before you have any transfusion. And it needs to be done because of that possibility of developing alloantibodies. You may have been transfused in the past, you didn't have an antibody before the transfusion, but after the transfusion you develop one. And before you get another transfusion, we need to know that so that we can select appropriate blood for you that does not have the protein you're now allergic to. The other transfusion testing that we do and that you might see a report on is called the DAT, or the direct antiglobulin test. If you have an older physician, he might call it the Coombs test. It's an eponymous name for the guy who developed this testing decades ago, I guess. So this test detects autoantibodies, which in contrast to the previous test of detecting alloantibodies, autoantibodies are antibodies against your own blood that your body accidentally makes. So if any of you have ever heard of a term called hemolytic anemia or autoimmune hemolytic anemia, that's a disorder where your own body makes an antibody against your own red blood cells on accident, which causes the destruction of those red cells inside of your own circulation. And the reason why I bring up this test, which is quite specific, is because oftentimes people with lymphoma can develop an autoantibody in the background. We're not exactly sure about this association, but it's something we check quite frequently, especially in patients with lymphoma. If your hemoglobin is found to be low on your CBC test, your physician might often ask for a direct antiglobulin test to make sure that it's not autoimmune hemolytic anemia. The other interesting thing about autoantibodies, the last point on my slide, is that these actually may or may not be a problem. Some patients develop autoantibodies that actually don't cause their red cells to hemolyze or break down. So we always have to follow up with another CBC test to see if your hemoglobin is actually getting lower. Hence all the follow-up blood tests. So to help you out in being a more savvy patient, it's helpful to know what your blood group is and what it's okay to get. Mind you, we'll always test this when you come into the hospital and need a transfusion. You're never required to know this on your own, but it is useful knowledge to have. So I mentioned that I was group O positive. As you can see by the chart, if I'm group O, I can only receive a transfusion from a donor who's group O. If my friend was group AB, which is much more rare, he could actually get blood from a donor who was group A, group B, or group O, or group AB. Now, if your if you have the Rh factor, so you're called positive, you can get positive or negative blood. But if you're Rh negative, you can only get negative blood. And the reason why it's important for you to know this sometimes is because if you've developed an alloantibody, so an antibody against other people's blood, we'll have to ask for a very specifically matched product. Thankfully, Canadian Blood Services and in Quebec, Quebec, have very extensive registries of donors, so they can tell us who has what proteins on the surface of their red cells, and we can get special product that your antibodies won't react against. It might not always be your exact blood group. So I'm O positive. If I had an alloantibody and we had to specifically get a unit that's okay for me, that my alloantibodies do not attack, I might get a unit that's O negative, just because it's also matched for those minor antigens. But that's okay. And so it's sometimes nice to know which products you can actually get. So I just wanted to talk about more special tests as well. We've talked about a lot of the common tests that you'll have done again and again, but there's a few special tests that are really useful in your care. I've mentioned a couple of them already, but I wanted to just speak about them in more detail. So flow cytometry is the one where we use lasers to interrogate every cell one by one. Actually, we take the sample of blood at first, and we label the cells with up to 12 different fluorescent molecules all at once, all on the surface of each cells. And then we run the cells through the machine, one by one. 5 lasers look at them at the same time. Depending on what fluorescent molecule has attached onto the surface of those cells, depending on what cell markers they have, those lasers are reflected off the cells in a very specific angle. All of the laser beams reflected off are captured in mirrors, and all of that stuff is turned into data in the computer. We can look at literally tens of thousands of cells in just a matter of minutes. This test is infinitely useful for us because we can differentiate all of the different populations of white cells in your blood, one from another. We can look at ones that are normal and ones that are abnormal. Leukemias have certain cell markers on their surface that normal cells do not, and the same with lymphoma cells. So this test is very useful for categorizing different blood disorders. The next test on the list is cytogenetics. This test looks at the chromosomes inside of your cells, and it's specifically useful these days because we know certain chromosomes are associated with certain cancers. So we're able to actually grow the cells up in a petri dish, expand them, and then separate these chromosomes out of the dividing cells and look at them one by one to see if they have chromosome abnormalities. The final test on this list is molecular testing. And now molecular testing gets even more specific and looks at the DNA that makes up your chromosomes, that makes up your cells. So this looks at specific genetic mutations inside of the cells. And why are these 3 tests so important? Well, because oftentimes we need to see more than just the morphology of the cells. I might be able to look under the microscope at your blood or your bone marrow and see that cells look more or less normal. But we need to better determine whether they truly are normal cells or whether they're just masquerading as normal. And also, once you've been diagnosed with a blood disorder and have been treated, these tests really help us to better determine whether you're in true remission or not. So you might hear people talking about morphologic remission, cytogenetic remission, and molecular remission. And that just depends on which level of special tests we're looking at. Flow cytometry looks at the cell level, cytogenetics looks at the chromosomes, and molecular testing looks at the DNA level. So obviously being in a molecular remission is much stronger remission than it is to be in just a molecular or just a morphologic remission. So your physician will determine what tests of these that he or she really needs to look at in your case. But a lot of times the lab will reflexively do all of this stuff in the background to really help determine your remission status. So before I close, I've talked a lot about a bunch of tests and why you need to have them done again and again. But I think I would be remiss without giving you some power in the situation. There's a concept called a diagnostic stewardship, and something that was developed more recently called Choosing Wisely Canada. And this really refers to practitioners' choice of when to order any sort of test, actually not just lab tests, but radiology tests or any investigation. And so if you go to this website, choosingwiselycanada.org, you can see a whole bunch of tools that are intended to start a conversation between patients and providers. So as you can see, there's a poster there that says, when it comes to your health, sometimes less is more. They say, next time you see your doctor, have a conversation. Do I really need this test? What are the downsides? What happens if I don't do this test? Is there any alternative? So Choosing Wisely Canada has been around for a few years now, and more physicians are starting to get on board with being very selective about what they order and whether it's really going to make a difference to their patients. And I think patients are now becoming more and more empowered to be able to talk to their physicians and nurses about all of these tests, what they mean, whether they really need them, and how they're explained to them. So I think this is about the end of my talk, and we have 20 minutes left for questions.
Thank you so much, Dr. Dallas, for shedding some light on complete blood count tests and their importance. We will now take some general questions. Please remember to use the chat function to ask your questions. We may not be able to get to all of those questions. However, we will do our best to answer those offline within the coming week. But for now, let's take a few. I do have one here. So what does the BCR-ABL test show?
Oh, so can you hear me?
Yep.
No? Okay. So BCR-ABL is actually a very interesting fusion protein that's caused by a genetic translocation. It's usually associated with a specific kind of leukemia called CML, or chronic myelogenous leukemia. It can a few times it can be seen in other kinds of leukemias as well, but it's just an error in the cells in where one part of one chromosome fuses to another part of the chromosome. It makes a fusion protein that causes the cells to be overactive and cause this leukemia phenotype. So that's a test that we always have to see by cytogenetics.
Thank you. Another question, is the lumbar test dangerous?
I would say if you have this lumbar puncture done by someone who is not experienced, it could be. As medical trainees, though, we're all taught very specifically how to perform this test. And if you are seeing a hematologist or oncologist who's even further specialized, this test should be something that they are very comfortable with doing. So I would not particularly be worried about having this test. As with any test, I mean, even having your blood drawn, there's always some tiny bit of risk. But the way it's done, we actually don't have much of a risk in touching the spinal cord, for instance.
Thank you. Next question. Why do we need irradiated blood?
Oh, so irradiated blood is a very interesting question. So in certain patients who have extreme immune deficiency, and so this is usually not the majority of us with leukemia and lymphoma. It's a small subset who have extreme immune deficiency. There would be a possibility for tiny numbers of contaminating white cells in a transfusion to, let's say, home to your bone marrow and set up shop. That could cause something called graft versus host disease, but caused from the transfusion. In order to mitigate that, what we would do is irradiate the unit of blood to kill off those tiny numbers of contaminating white cells. And when I talk about tiny, it really is tiny. All the blood that's produced at Canadian Blood Services or Héma-Québec is filtered before it's ever stored. There's barely any white blood cells left in those red blood cell units, or platelets for that matter. But in someone with extreme immune deficiency, there's just a few kinds of leukemia or lymphoma that would impact. Also, a few kinds of congenital immune deficiencies. That's when we would need to use irradiated product. There's actually, I think a lot of physicians have been more concerned with this because in the past, blood was not produced in the same way, so it wasn't as safe as it is now. But these days, it's actually very few patients who would need irradiated product.
Thank you. Next question, can you please discuss WBC differential testing results?
Oh yeah, so that is basically the whole list of different white blood cells that I put up on the slide that talks about the CBC, the first slide. So there's neutrophils, lymphocytes, monocytes, eosinophils, basophils. So when we say a CBC with differential, that's what it's talking about, is that we break the white cells down from one big number into all the small components that make up the white blood cells. So these days, the fancy analyzers that we have almost invariably do that automatically. In the past, when we had to do a CBC manually under the microscope and count up all the cells, there was an option to just do a white blood cell count by itself, and we didn't say what kind of white blood cells all of those ones were. So I hope that answers the question.
Let's see, I didn't get a response, so I think so. All right, let's see the next question here. With lymphoma, would a drop in platelets but no other change be indicative of leukemia?
In lymphoma?
Yes, it says with lymphoma, would a drop in platelets but no other change be indicative of leukemia?
Yeah, so the easy answer is no. But I think we're trained in medicine to always see the what if possibilities. So I think what the person who asked that question might be getting at is with lymphoma, sometimes chemotherapy can later down the line cause a secondary leukemia, in which case a drop in platelets might be the first thing that you see. This would be very rare. Usually you would see leukemia cells or blasts in the circulating blood.
Great, thank you. Another question. Could you please explain why a lactate dehydrogenase test is ordered? What happens if the level is too high?
Oh yeah. So this is one of the ones I did not discuss because it's not as common as the other ones, but a lactate dehydrogenase or LDH test is one of the enzymes that's inside of red blood cells. Incidentally, it's also inside of liver cells. So if you have liver failure, you can have a high LDH level, but mostly with blood diseases, we're probably looking at this as a marker of hemolysis. So that condition that I talked about where your red blood cells are breaking down inside of your circulation. So there's something called a hemolytic workup. If your physician was worried that you might be having hemolysis, he or she could order this panel that includes LDH and a few other things, including the DAT that I mentioned, to evaluate whether you're having hemolysis.
Great. Let's see here. So how low do the platelets have to go if you are also on anticoagulant before there is a concern?
Yeah, so it generally depends on which kind of anticoagulant you're on. There's actually a whole bunch of different kind of blood thinning medications. Some of them affect the platelets and some of them affect the coagulation factors. So in general, the platelet count threshold that we get concerned about in an average patient is a platelet count of 10. And underneath 10, your risk for spontaneous bleeding goes up. So that's when we usually transfuse patients. In someone who's on anticoagulant medication at the same time, we might give that threshold a little bit of a bump and care about a platelet count of around 20. So it totally depends on your clinical situation though, if you've just had a surgery or if you're sick from other reasons, if you're on chemotherapy. So everything, you know, as with many things in medicine, is patient specific. But those are kind of general numbers, platelet count of 10 and then platelet count of 20.
All right, thank you. Next question. What is the, and pardon my massacre of this, I hope I get it right. What is the creatinine test?
Creatinine.
Creatinine.
Creatinine is a chemistry test, and it's a measurement generally of renal function or kidney function. So often declines, or the creatinine would probably increase, but the kidney function over time would decline with age. It also sometimes declines in people who've had chemotherapy or who have, you know, ongoing medical illness. But it's just a general test to look at kidney function.
Okay. Quite a few questions here. So here's another one. Where do you find your percentage of blasts on a CBC blood test report?
In fact, that's usually going to be in the white blood cell differential that we just talked about a little earlier. So you would usually see the percentage of neutrophils, the percentage of lymphocytes, the percentage of monocytes, and then if there's any other cells, they're usually underneath the main list. So you see all those cells that I listed, and then at the bottom of the white cell differential, they will usually say blasts or others, and they will be in those categories.
Okay, so here, please discuss minimal residual disease testing, specifically molecular PCR testing, as an indicator of remission status.
Yeah, so I kind of touched on that in that that one slide that talked about all the special tests, the flow cytometry, the cytogenetics, and the molecular testing. So this is exactly the reason why those tests are done, to help determine the remission status of patients after they're treated. I mean, it's done up front to help diagnose disease, but once we've had treatment and then we're in remission or trying to evaluate remission, that's why we do those tests. So what we're looking for specifically is that initially your leukemia or your lymphoma might have been diagnosed specifically with one mutation or you know, more than one. But when we now look back at your blood or your bone marrow, we're looking for the presence or absence of that same mutation that you had at the beginning. If we don't find it, then we'll know that you're still in remission. But if we do find evidence of that same mutation that your original leukemia or lymphoma had, we will know that all the cells were not killed off. Or maybe we thought they were and now they're coming back, right? So we can still detect that abnormal DNA mutation. And then that would indicate you're not in remission. And this is really important. It's actually amazing how far blood cancer studies have come scientifically, because we're able to do so many blood tests again and again and again. I mean, this is not possible for other cancers of other organs, right? We can't take a sample of a brain tumor every single day, but if you have a blood cancer, we can. So that's why we've been able to identify all of these mutations and chromosome abnormalities over the years because of such advancements in science. So if we have proven that this one mutation is what caused your lymphoma or leukemia, and then now we find it coming back, we're going to know that you're not in remission anymore. And your blood might look completely normal. Your bone marrow might look completely normal, but the DNA level goes way deeper than what the cells look like.
Okay. So someone
clearly you can tell I love my job, right?
Absolutely. Let me see here. So I have a question. So basically this person's blood count is sometimes high, sometimes low, and doctor doesn't seem concerned. So this person would like to know, are there actually guidelines as to how much out of range is still okay, or is it vary person to person?
Yeah, it's really interesting. It does kind of vary from person to person. I assume that you're talking about the white blood cell count, but this could probably be applicable to every blood test that we've talked about. There's something called the measurement of uncertainty. And so that's just the concept that even this fancy analyzer in the lab, it's not necessarily going to get the exactly very specific same number every single time you measure something. And that's just the same with, you know, any test that we do in life, right? It's going to be very close to the right answer every time, but not 100% the same every time. Beyond that, though, there's actually normal ranges that are usually printed on the printout of the lab report. So you can know that if your cell counts are within the normal range, even though that might be real variation and not just that measurement of uncertainty about the machine, that might still be okay. It depends on what the trend is and what cell we're actually looking at too, right? So there's a bit of patient-to-patient specificity there. There's a bit of normal range variation. So for instance, my platelet count might be 200 today, but tomorrow I'm stressed out, and stress does cause a mild increase in platelet count. Maybe tomorrow my platelet count is 250. That's probably not measurement of uncertainty of the machine, but it's still within the normal range, so it's probably no big deal.
All right, thank you. Can you discuss low lymphocytes that do not recover long after chemo?
Yeah, so this is kind of interesting. This probably is pretty patient specific, and it might be many different reasons why your blood cell counts don't fully recover, and especially one little subset why they don't fully recover. Lymphocytes actually talk about several cells all lumped together. That's B cells, T cells, and NK cells. Sometimes we can have a genetic predisposition to having low lymphocyte count. Sometimes it's just one of those subsets of cells that doesn't recover very well after chemotherapy. Some kind of chemotherapies actually even specifically target those cells. So if anyone has ever heard of rituximab, that's a common one we use in lymphoma, and it particularly targets the B cells. So it all depends on what kind of chemotherapy, who you are, what kind of disease you had. And there's specific ways to test all of those as well. So if your doctor did think that was a problem, for instance, if you had recurrent infections, you know, we can actually analyze all of those subsets on the flow cytometry machine. So I would think probably as a patient, maybe don't be super concerned about that. If your doctor is, we can totally work that up in the background in the lab.
Okay, so we have time for maybe 2 more questions. So I have one here is, what would the anticipated neutrophil level of recovery possibly be back to?
Could you repeat the question, Simon?
Yes, absolutely. So what would the anticipated neutrophil level of recovery possibly be back to? I guess basically is what indication would show recovery in the neutrophil?
Oh yeah, so generally right after chemotherapy, we are looking for any little tiny bit of recovery, because many people get their neutrophil count will go down to 0 after chemotherapy. So even if it comes up to 0.1, we're like ecstatic. The kind of safe range though, where your physicians are not going to be concerned about you getting an infection or getting succumbing to infection or whatnot, would probably be like 0.5 to 1.0 on those blood test results. Normal range is usually considered at 2.0. But if you're between 1 and 2, you usually don't get sick. So underneath 0.5, people would probably be worried about you. Between 0.5 and 1, you're probably doing fine. And then above 1.5 or 2, you're in the normal range. Right after chemo, when you have 0 count, we don't even care. If we see some neutrophils coming back, we're happy.
All right, so let's do one more question here. So after bone marrow indicates remission, how frequently should a bone marrow be repeated?
Well, that generally depends on your type of leukemia or lymphoma, what your physician sees going on with you in your clinical picture, and what the results of your CBC are looking like. Because our normal protocol and your clinical status might indicate one thing, but if all of a sudden your hemoglobin or your platelets are going down, even if we see just one immature cell in your peripheral blood film, for instance, that might warrant repeat bone marrow examination. So this one really is pretty patient specific. If everything else is like status quo, perfect, no symptoms, no changes in blood tests, then your physician will probably extend things longer and longer in between follow-up blood tests. So I have patients that I see, you know, maybe once a year for follow-up bone marrows. Other ones who extend even longer, the longer they are out, you know.
Okay, thank you. So we'll terminate the question period now. However, as I mentioned before, although we may not get to all of them today live, we will do our best to get back to you within the following week. So I do have all these questions, and I will be able to review those with Dr. Dallas. So I would like to thank everyone for participating today. I'd also like to mention that please do not hesitate to contact us if you need more information. You can do so by calling toll-free or by email at canadainfo@lls.org. Also check out our website regularly for the dates of our upcoming webcasts or to watch all the past webcasts as well. So please note that a short survey will be sent to all participants after this broadcast. We would greatly appreciate you taking a moment to fill it in, as it will help us to offer you the most valuable information in the near future. Once again, thank you so much, Dr. Dallas, for sharing with us. Very much appreciated. And thank you everyone for joining us. Have a nice day.
Thank you very much.